Well, thank you everybody for joining. Like Haley said, I am one of the fertility specialists seeing patients in Los Angeles. I am the medical director here in LA. I am also one of the chief medical officers of Kindbody, and I work on clinical development here. So it is a pleasure and honor to serve my patients and Kindbody in all of these different manners. So really, I'm really looking forward to talking about pregnancy loss and infertility because they do many times go hand in hand. So many patients who have infertility also have a pregnancy loss as part of their journey. And there is another group of patients that sometimes they don't have a challenging time, or it doesn't take a long time for them to get pregnant, but every time they get pregnant, they lose the pregnancy. And so all of those patients and what is happening to them and their experiences are often intertwined and very similar. And so very important to just kind of address those particular things when it comes to infertility. So that's me. If you want to get a hold of me on Instagram, you can always do that, or any socials. I am available. But first, if you guys don't know that much about Kindbody as a company, I'm really proud of what we're doing to make reproductive health and fertility care accessible to everyone and to more people, because it just really isn't in the United States as it stands now. And so we do that and we work directly with patients. We also have our own benefit that we work with employers. So if your employer does not cover fertility benefits, you should talk to your HR person and pressure them to do so. It's really important. And companies like Kindbody can be providing those benefits, which is such an amazing thing to increase access to care. At Kindbody, we do cover the gamut in terms of what we handle in our clinics. And so we do fertility consultations, both virtually and in the clinic for men and women. We do egg and sperm freezing and embryo freezing. We do IUI, IVF, donor egg, donor sperm, genetic testing. We also have at-home fertility tests. So we really run the gamut of fertility treatments. In terms of the types of counseling and support, we also, I think that's a big part of our mission, is to really kind of provide that 360 care for our patients. And so we have specialized LGBTQ plus support, support for our patients that are using donors, whether that be donor eggs, donor sperm, or donor embryos, patients using gestational carriers. We have our own in-house surrogacy agency, and we have our own donors, but we also have patients that use donors that are not kind of within in-house. We're just trying to make the process easier, trying to make it easier, more efficient for patients, and that's truly our goal. We have a lot of other services that we provide. For example, we have contractors that we have worked with that really focus on kind of what we want them to provide in terms of nutritional counseling, focusing on PCOS and fertility, even lactation. And we have a whole composite of therapists that work with our patients to help them with their mental health and wellness and well-being. And I have had so many patients that have taken advantage of those services over the years, because even if they have their own therapist that they see regularly, sometimes someone to just have a one-time quick appointment to kind of help you in that moment is something that is very important and really needed. So what we're going to talk about today is we're going to talk about pregnancy loss and how it is related to infertility. And I'm not going to discuss every single test that we can do, but I'm going to try to just give a broad overview of the reasons that patients do have pregnancy loss, and also how it is sometimes also tied in with infertility. And so sometimes what are the testing mechanisms that we might offer, and what are some of the treatments. So we'll kind of cover some of these genetic, anatomic, hormonal, environmental causes, as well as some of the treatments, and then also kind of really navigating the emotional side of having a pregnancy loss. So I think it's usually very surprising to people to understand and know how often miscarriages occur. Miscarriages occur in 15 to 25% of clinically recognized pregnancies. That is a lot. That means that if you have friends that are trying to get pregnant around you or have tried, is that you probably have a friend that's had a miscarriage and they may or may not have shared it with you, because sometimes it can be really hard to share that information. So miscarriages are just much more common than people think about and recognize. It is less common for patients to have two losses in a row. Only 3 to 5% of patients have two losses in a row, and even less will have three losses in a row. That's usually less than 1%. The old adage, and I think what is still kind of in place if you look at a lot of the guidelines, is that if you've had three or more consecutive losses, it is, time to speak with a fertility specialist like myself and have a workup done and understand what the potential causes are. I will say that most providers will actually jump in and do the testing at two losses, not three. And I think that's for a couple of reasons. I think that there's some data that suggests that the chance that you're going to find an abnormality is actually the same at 2 weeks or with two losses versus three. And so, why wait? Like, why would you wait? That's my view of it. Like, why would you wait for three when you could intervene at two and maybe prevent that third loss from even happening? One of the things that can also get a little confusing is what is defined as a loss, right? Is that just having your period that comes 4 days late, and maybe you do have time to do a urine pregnancy test and maybe you don't, and you think you were pregnant, maybe you have felt a lot of symptoms of pregnancy, maybe you did a urine pregnancy test but then started bleeding a week after. And then there are the losses where you are 8 weeks and further along, and those are all different losses, and the cause of those losses, they can vary depending on when you are losing the pregnancy. And so it is important that if you have any losses at all, that you speak with your provider so that we can provide clarity and some expertise on what's going on. If you've had miscarriages, the chance that you'll have another miscarriage in the future is higher. So for example, if you've not had another miscarriage, and this is probably for a patient who's under the age of 35, maybe your risk of having a miscarriage at the age of 31 is 10%. But if you've had one loss, then the chance of having another miscarriage does go up. It almost doubles. And then if you've had three, it goes up again. And so the more miscarriages you have, right, the more likely it is that you might have another miscarriage. And intuitively, that makes sense because there might be an underlying cause that's causing these miscarriages. And if we can just get in, figure out what that cause is, and then intervene and fix it, then we can prevent that another miscarriage from happening. So kind of get back a little bit about the timing of the miscarriages. So what is pre-embryonic, which is kind of conception to the end of the 4th week. So this is literally like right at your pregnancy test, versus what we would consider embryonic, which is the 5 weeks all the way up to the 9th week. Those tend to be more often genetic. All right, the earlier the pregnancy, the more likely it is that it's a genetic issue. As the pregnancy progresses onwards and kind of gets closer to 10 weeks, then those are ones that are less often genetic and tend to have a higher proportion of causes that are potentially anatomic or thrombotic, which is essentially just clotting. And so it is important to when you're kind of talking with your provider to just kind of walk through, and they will always ask, as I do, of like, okay, tell me about this first loss. When did you have symptoms? When did it happen? Tell me the story. And so then we can kind of figure out and sometimes customize the workup to what you're going through. And sometimes it's a matter of like, okay, based on your clinical history, we automatically have to do these things. Here are a couple of other tests that are kind of really considered as part of this workup, but maybe are less applicable to you. And then you might, your provider might work with you and say, okay, you have the options of, do you want to do this now or wait and defer that test for the time being? So there are many different types of losses. So there are losses that are related to maternal age and chromosomal abnormalities that happen as the egg develops. There are inherited genetic abnormalities, meaning that there is something in the chromosomes or DNA of the parents that is getting passed down, and that is increasing the chance of miscarriages. There's issues related to the uterus. There are endocrine issues. There are potentially, we think, maybe some immunologic issues, and then thrombotic, infectious, and environmental. So let's kind of speak first to genetics, because this really does make up the vast majority of miscarriages. So for women, as we get older, we have an increased number of abnormal eggs. I don't usually like to say that we have abnormal eggs, because it's not that they're abnormal from the get-go. It's really just that the eggs that we have in our ovaries were there since before we were born. And then at the time of ovulation, so when the ovary is releasing the egg and you're trying to get pregnant, that egg is going to have to go through its final stages of development. And because of oxidative stress and other things that have happened over time, that egg's ability to develop normally as it's ovulating and kind of going through those last minute developmental stages, its ability to develop normally goes down as women get older. And so that's actually the cause of infertility that's related to age. It's the cause of why miscarriages go up with women's age. And you can see that from this graph here of the differences in the miscarriages as women get older. And then also, it is also what causes things like Down syndrome, Turner syndrome. So all of those have their origins in the same thing of that egg just not developing normally when it's ovulating. And so if it doesn't develop normally, then what ends up happening is the embryo itself, so that's the egg and the sperm when they join together, the embryo will have an abnormal, I'll show a slide in a second, but we'll have an abnormal chromosome count. The chromosomes are little structures that have DNA. And so we call that an aneuploid embryo. So that just means an embryo that has an abnormal chromosome count. And you can see the gray bar, the chance that if you have an embryo that it is going to be abnormal goes up greatly with age. And it's these chromosomal abnormalities that are actually the number one reason why people miscarry. And so again, that's kind of why the live birth rate goes down. And so unfortunately, for women as we get older, especially in your 40s, and there's like a 75% chance when that egg develops that it's not going to develop normally, and therefore the embryo will be chromosomally abnormal. So this is actually kind of a really great picture down here below on the right of like what's happening in the egg as it literally is getting released from the ovary. So it's trying to separate out these chromosomes. And ideally what is happening is that like everything's kind of getting evenly distributed. And the egg itself has extra copies of the chromosome. And so it's truly trying to get rid of these extra copies of the chromosomes, or this extra DNA. And so I always like to think of it as these little mechanical parts inside of the egg. And when they're kind of grabbing, and you can see these little mechanical parts, these are these like little gray they're called microtubules. They're grabbing the chromosomes, and sometimes they'll grab too many, or sometimes they won't grab enough. And so therefore the egg is going to be left with too many or too little of these chromosome structures. And then when it joins with the sperm, it's imbalanced. Right. And so this is an age-related phenomenon. It can happen to anyone. Having an embryo that's chromosomally imbalanced that will lead to a miscarriage can happen to anyone. It can happen to someone who's 22 and someone who's 45. It's just that, again, as our eggs are older, there's going to be more likely that there are these chromosomal abnormalities in women that are older. But this is truly what accounts for like over half of miscarriages are just caused by these chromosomal abnormalities, which is super important to remind women that it's nothing. It's not like I think a lot of times we're like, what did I do wrong? Is it me? Like, can I hold a pregnancy? When most of the time when you have a miscarriage, it has nothing to do with your ability to carry a pregnancy. It is really just the embryo itself, that it just has the wrong number of these chromosomes. And so there's just no way that no matter what you did, how you lived your life, et cetera, anything that was going on, there was nothing that was going to change that. And so this embryo was going to eventually miscarry. One of the other things that we look at when it comes to genetics are inherited genetic abnormalities, right? And so these are related to those chromosomes, but there, if you think about them, we have chromosomes, right? So all of our DNAs and chromosomes in our body. And so there are 23 different chromosomes, and the chromosomes are supposed to kind of hang out with each other. So chromosome 1 is supposed to hang out with chromosome 1, chromosome 2 is supposed to hang out with chromosome 2. But sometimes these chromosomes, and because they have different DNA and different DNA that has genes that control different things in our body, they're not really supposed to kind of intermingle, right? But what ends up happening sometimes in some of our bodies is that these chromosomes that are not alike kind of get too close to each other, and then they swap material. And so you can see that if you look at this bubble in parent 2, this parent 2 has these a chromosome that were like somehow like at this bottom here, these little chromosomes got too close together. And so now this chromosome, look, it's almost all red with a little bit of gray. This one's mostly gray with a little bit of red. And then when we as biologic parents pass down our DNA and our egg and sperm, you're not passing down everything. You're only passing down half, right? Because there's a pair of each of these 23 chromosomes. One came from the egg, one came from the sperm. So I only, in my eggs, right, as a biologic female, I am only going to pass down half of my DNA. And then the other half of the DNA that is going to become this eventual child comes from the sperm. And so when you're passing down your DNA, you're only going to pass down half of your chromosomes. So depending on which chromosomes this parent is going to pass down, whether it's these ones that are here completely normal or it's these ones that have the rearrangement, now all of a sudden there is just a higher chance that you're going to have an embryo that has kind of excess material or is missing material. And then depending on which chromosomes are involved in that, that can kind of determine the fate of that embryo, whether it actually leads to a miscarriage or, you know, a baby with an issue that has a syndrome related to that extra or missing chromosome. So what we do in order to test this is we get something called a karyotype. This is a blood test that both parents get. And we're looking at each of the chromosomes and just making sure there's no of the rearrangements. So we find that about 3 to 5% of couples, one of the biologic parents will have one of these rearrangements in it, and it's causing these extra miscarriages. So in both of these situations where you have abnormalities that are related to chromosomes and excess or missing chromosomes, so whether it is related to maternal age and the egg, or it's related to a chromosomal rearrangement, the way that you can avoid putting in an embryo and having an embryo that has that abnormality that's going to lead to a miscarriage is doing something, you know, called pre-implantation genetic testing for aneuploidy, right? But this requires IVF to do what we call PGTA, right? So you have to do IVF where you take eggs and sperm and put them together and we make an embryo. And these are embryos here on the right. And then what we can do is the placental cells are the cells that are on the outside of that embryo. And we pull out about 5 to 10 of those placental cells. And then in the case where you're just trying to see if that embryo has the correct number of chromosomes, then that's where you'll do PGTA. In situations where you're having those rearrangements, if those rearrangements are such that the normal PGTA testing wouldn't be able to see the rearrangements, then you have to do something called PGT-SR, which is just a segmental rearrangement. And sometimes it's a different type of testing. The biopsy is done the same, But once we send the biopsy, those cells to a company, they just test for it in a little bit different way. And so this can vastly decrease the chance of miscarriage. So this is oftentimes a treatment that many patients who have had multiple losses will consider doing. When we think about structural abnormalities, these are uterine factors. So the uterus is actually a really complex organ. When as women, when our uterus is being formed, when our mothers were gestating us, right? And inside our bodies, what's happening is there's actually like two uteruses that kind of come together to make our one uterus. And sometimes that in that fusion, something goes wrong. And so here, this is essentially you have those two kind of halves of the uterus that never fuse. And so women can be born with these congenital anomalies, and we think that about 7% of women have some form of a congenital anomaly. They're not all necessarily this severe, but they can cause problems, and some of them can cause problems that are related to pregnancy loss. And so in fact, we think that these anatomical abnormalities can cause about 10 to 15% of pregnancy losses. In order to kind of diagnose them, it often can take multiple different types of imaging studies. Sometimes this is something that even just on a regular ultrasound, we might see a suggestion of something, but then in order to really classify it, we would want to do a water ultrasound or an MRI so that we can kind of truly figure out exactly what's going on with both kind of the shape of the uterine cavity and the outside of the uterus. The most common congenital anomaly of the uterus, and the one that most commonly causes miscarriages, is something called a uterine septum. The nice thing about a uterine septum, unlike some of the other congenital anomalies, is this actually is oftentimes very treatable. So a septum is essentially, so when the two kind of half of the uterus is kind of fused together, this cavity is actually filled with fibrous tissue, and it resorbs from the bottom up, and so it kind of disappears. And sometimes you have a remnant of that fibrous tissue that gets left in place, and that's what a septum is. This is a really severe septum here that is kind of notated on the right in this cartoon, where it's going all the way down to the cervix. So that's a really severe septum. I would say the vast majority of septums that we see are pretty mild, and they're just kind of at the top. The really amazing thing about septums is that if you see them, we can fix them. So it's really nice if there's a problem that you have a solution, because that's not always the case. It's oftentimes not the case in what we do. So if you have a septum, we can go in and we can put a camera through the cervix and get into the uterus. And actually with some scissors, this is actually an image of the inside of the uterine cavity, and you can see the septum here. And this is one that's very easily removed with scissors. And once you remove that septum, the chance of having a miscarriage goes back to normal, because now the uterine cavity is normal. So it is a very satisfying thing to be able to treat so that you can really minimize the chance of miscarriages in the future. There are some hormonal factors that can cause miscarriages. So when there are extreme abnormalities in thyroid's the gland, right? Our thyroid gland is right here in our neck. It controls our metabolism. And so with the thyroid gland, when that is at extreme levels, either really low or high, there are some associations with miscarriages. And then same thing with something called prolactin. The prolactin is a hormone that's secreted in our pituitary. It is one that is most often associated with breastfeeding after having pregnancies. But all women secrete a little bit of prolactin. And when we secrete too much, sometimes you just have too many cells within the pituitary that are secreting prolactin. That has also been associated with first trimester losses. And so that's something that we would always check. We usually will check the prolactin. If it's elevated, we'll do a second one to check it fasting, because that can sometimes make a difference. And sometimes we have to do an MRI to look at the pituitary. Again, this is both of the thyroid and prolactin are very treatable with medications. And sometimes what we often find, by the way, with losses is that sometimes we think your losses have different causes. So even women who have septums, it doesn't mean 100% of the time you're going to miscarry. And so it's always important to look at the whole picture. Even if you found a uterine septum right away, I wouldn't ignore any of the other things, because if you've had 3 or 4 miscarriages, it's possible that 2 of them were from the septum, but the other 2 had nothing to do with the septum. One was genetic and one was something else. And so that's something that is always something that we kind of keep in mind, is that not all of the miscarriages that a couple has suffered are all caused by the same thing. Women who have PCOS have a little bit higher rate of miscarriages. It's kind of a mystery as to why. And unfortunately, there's not much that we can do to minimize it. There's not any data at this point yet that shows kind of some of the medications or supplements that we use, like metformin or ovasitol with women with PCOS, that those can actually decrease the miscarriage rates. I don't think that this is going to be a mystery forever. I think that we'll hopefully in the next 10 years can kind of try to figure it out, but it is a little hard to tease out. And women that have uncontrolled diabetes also have a higher risk for miscarriage. And so the other thing that I oftentimes will have patients ask me about is is my body fighting off a pregnancy? Is there like an autoimmune, or not really autoimmune, but an immune response against the embryo that is causing me to lose miscarriages? And so there's not a lot of data. I will tell you, people have been looking at this for a very long time. I did research on this, and my research was after people doing 10 to 15 years of the same research, and this was 20 years ago. So it's like 30 years. People have been really trying to understand the maternal immune response and how that's related to miscarriages and even failed implantation. And it's really muddy, and there's very little data to support testing for different types of immunological deficiencies, outside of some of the other things that we'll talk about in a second that are autoimmune, that are clotting disorders. So I think it's just really important to know that this is a very complex subject, something that we're thinking about all the time. But there are people that offer some patients tests where it's like a whole panel of tests, but it's like you pay $5,000, $10,000. It's a lot of money for these tests, and there's not a lot of data at this point to really support their use. Like, what do you take away from it? How do you treat it if you do find an abnormality? There's something called antiphospholipid antibody syndrome. It's a clotting disorder. It is antibody mediated. Right. And so in order to have antiphospholipid antibody syndrome, or APS, essentially you have to have 3 losses in the first trimester before 10 weeks, 1 preterm birth before 34 weeks related to preeclampsia, which is high blood pressure or a placental issue, or a demise beyond 10 weeks. In addition to those clinical criteria, you have to have there's 3 different tests that we look at for 3 different antibodies, and one of them has to be high level positive, and it technically has to be the positive 3, and you have to do 2 tests 3 months apart. It is actually a not so uncommon cause of having losses. 5 to 20% of our patients with recurrent losses will have this. And this impacts the pregnancy, because pregnancy is really complicated, and that you have the placenta that's growing into the uterus. And so if there are blood clots that are forming as the placenta is attaching to the uterus, that could interfere with the normal blood flow and everything that the baby needs to grow. And so that can cause and lead to a miscarriage. Usually these are miscarriages that are 8 weeks, 10 weeks, much more so than something that's happening at 4 or 5 weeks. The good news with antiphospholipid antibody syndrome is that there's treatment. So we can give patients baby aspirin and a blood thinner that's either heparin or Lovenox. And by treating it, we can minimize the chance and kind of bring that chance of having a miscarriage back to baseline. So again, this is something that I don't want to find this in anyone, because it means you're going to have an increased blood clot risk all over your body, not just related to miscarriages. You could have like a DVT in your leg. So I don't want to find this in anyone, but if we do, in some ways I feel really lucky, because maybe we're going to have not only a positive impact for them to have a baby, but it's something where we could really prevent like a medical catastrophe later in their life. right? Because we can go ahead and treat it. In terms of environmental, there's a lot of environmental factors that have been associated with a higher chance of miscarriage, right? And so that's smoking, alcohol, and this is both paternal and maternal, by the way. It's not just maternal, drug use, and then high levels of coffee. So please, if you are a coffee drinker, you can have a cup of coffee every single day. It's not going to increase your chance of miscarriage. But high levels of caffeine, and it's not just coffee, but it's any caffeine, can be problematic and have associations with increased loss. And then other things in the environment, like elevated levels of BPA, which is in plastics, parabens, insecticides, all of those at very, very high levels have again been found to have some association with losses when you look in the literature. And so in terms of an evaluation, we're going to look at all of these things. There are some other tests that other, providers might talk to you about. Sometimes we want to look at inflammation inside the uterus. And so you might hear from some providers, they might just give you a round of antibiotics, or they might want to do a biopsy to look at some inflammation. There's some newer data that's come out probably in the last 10 years, actually looking at something in the sperm. And that's looking for something called sperm DNA fragmentation. So sperm DNA fragmentation is essentially a measure of when the sperm is traveling from the testicle into the ejaculate, it's being bombarded by free oxygen radicals. So free oxygen radicals are essentially, think of them as the breakdown products of metabolism. But when we break down things in our body, we kind of get these toxic things at the end, and it's not great for our DNA, period, anywhere, but it can really damage the sperm and damage the DNA in the sperm as it's traveling from the testicle to the ejaculate. And so sperm DNA fragmentation is just a measure of how much the sperm is being damaged. And so sometimes at lower abnormal levels, we might advocate for patients to go on high level antioxidants. If the sperm DNA fragmentation is really high, we actually will probably refer you to a urologist to have them talk about, is it worthwhile getting sperm directly from the testicle instead of using sperm from the ejaculate? Because then you're getting the sperm that hasn't been damaged during that kind of 2 to 3 month travel journey from the testicle into the ejaculate. So those are some additional things that some providers will talk to their patients about. I think they are a little bit more, I don't like to use the word controversial, but I think people just have differing opinions about how important they are, that they are things to consider. When we do the workup, right? So when we do the workup for couples, we find something about half the time. Half the time we'll find something that we can fix. The thing to remember is that if we fix one thing, we're not fixing everything, right? So let's take an example. You have a woman who's 43. She's been trying to get pregnant for 3 years, and she's had 3 losses. When we do a workup, we find a really small septum, and you fix the septum. Is it appropriate for that patient just to continue to try to get pregnant on their own for the next year and a half? Well, unless with those miscarriages, that patient did genetic testing, and we know that the genetics of each one of those embryos was normal, and that this patient probably was more likely having the miscarriages just from the septums, you might assume that maybe, yes, so you have had 3 or 4 miscarriages, maybe 1 or 2 of them came from the septum, but the other ones came from being genetically abnormal. Maybe those losses were earlier, so we are more likely to be genetic. So it is important to not just assume when you find something that is the cause of everything. And so that's why it's really important to work with your provider, understand your specific history, and then make decisions that are really good for you. I have had, and I really mean that good for you, meaning the true for the patient, what feels right. I have patients that have had 2 losses, and from those 2 losses, they're in the mindset that they never want to have a loss again. That was very traumatic for them. Maybe they did have like a really traumatic one where they had to have a D&C and multiple procedures to, there are times when it can be harder than other times. And so, maybe they really don't want to experience another miscarriage. And I have had patients that go directly to IVF, even when they're young. In some instances, it's really useful. You do the IVF, you do the testing of the embryos, and sometimes you find out even for young patients that there's like a higher proportion of embryos that are abnormal. And you're like, oh, now it makes sense why you've had these losses. Like, for whatever reason, like your chromosomes are just sorting it in a way that is more likely to be abnormal. So I think you have to take the entire picture into context when making a decision of what makes the most sense. And everyone, you could have two couples that have very similar situations and they might choose different things. Like one couple might try to continue to get pregnant on their own, and the other one might choose IVF, and that's okay. At the end of the day, you have to feel very comfortable with what you want to do. I think also the other thing that's important is to really just think about, even though the loss, like the more losses you have, the higher chance it is you're going to have a loss in another pregnancy. It's probably more likely that you're going to have a baby. It is more likely that probably even if we do nothing, right? Because a lot of patients, we're not going to find anything. So just by statistics, it's more likely that when you get pregnant again, that you will be able to have another baby. And so, yes, even having more losses, as you can see, more losses going from like yellow to blue to gray to light gray, more losses does make it a little bit lower that you'll have a live birth with your next pregnancy, but it's not dropping it by 80%, certainly. And that obviously those numbers will very much depend on how old you are when you're trying to get pregnant, because that's going to make a big difference, right? So, miscarriage, an average miscarriage rate at the age of 45 is 50%. So age has so much to do with this. I think it's really important, no matter when your loss is, whether your loss is at 5 weeks or 9 weeks or later, whether once you found out there was a loss, whether it was easy or it was, more complicated for everything to resolve, it can be extremely challenging, and it can be very hard as a patient to work through and process everything. And so I think that we have to acknowledge that any loss is a loss, and it may impact you in a very similar, if not identical way. And so that's why we think it's really important to have our therapists available, because sometimes they just have the expertise that, if you have another therapist, they can help you, but they don't live and breathe this world that we do. And so having someone to talk to can be really something that is incredibly important as you're going through that. And so making sure that you kind of acknowledge and kind of, I think, importantly, know that anything that you're feeling, whether that's anger, sadness, all of those emotions are okay. And to ask for help and to need help to navigate that is 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 laudable, and is something that we, like, if someone's giving you support in any aspect of your life, like, let's give the support that's there. Let us help you through this journey if this is something that you're suffering through, because we certainly don't want to make it any harder. We want to make everything easier for you. So I think that that's about it. I mean, there's so much we could talk to. I'm sure there's lots of questions that we can kind of go through.
Yeah, so thank you so much, Dr. Bendikson. We'll go ahead and start with the Q&A. We'll
Okay.
try to get through as many as we can. Yeah, so we'll go ahead and get
Yeah.
started.
Yeah, so I can see everything in the chat right
Perfect.
now, so I can do it. I think some of these I may have got to a little bit as we've gone through, but how many weeks is considered a loss, and how does this pertain to chemical pregnancy? So that's a great point. I didn't actually specifically call that out. So we have a name for a loss that happens really early at that stage where we're not able to see anything on ultrasound, and that's called a biochemical pregnancy. So remember, this is just our medical term, right? So it's a biochemical loss. What does that mean? Biochemical to us, from a very medical standpoint, means just in your blood, right? So we were able to detect that someone was pregnant only by blood, and we weren't able to see anything in the uterus. Again, it's not meant to kind of minimize that loss or and make patients feel that it's any different. I, in some ways, kind of loathe that name a little bit because it's just different. It is just a loss. It's just happened at an earlier time point in the pregnancy. But it is important to kind of differentiate those types of pregnancies because those tend to be more often genetic versus one that is at 10 weeks will have, more often to have like an anatomic or a thrombotic reason. What are the safer levels of TSH and TPO to prevent miscarriage? Yeah, so that's another great question. I will tell you, we all in kind of the fertility world have jumped on this bandwagon of, everyone should, when they're trying to get pregnant, should have their TSH levels below 2.5. But I will tell you that it's not so important that every OBGYN is checking every woman's TSH levels before they have a baby. And if it was so important that everyone had TSH levels before 2.5, then certainly we would be doing that. And everyone before they were going to have a baby would be told you need to go to your doctor. And if your TSH level is 2.9, then you have to treat it. So at some point along the way, we have recognized that there are some women that when their TSH levels are a little bit elevated, that in that population of women, there is a subset of them that once they get pregnant, they're not going to be able to keep up with the demands of pregnancy because once you get pregnant, the demands and the needs go up by 30% because the mother is not only providing her own thyroid, but also the thyroid hormone for the baby in the whole first trimester until the baby's thyroid gland is mature and can secrete thyroid hormone. So you have to be able to provide thyroid for you and the baby. But that means that your thyroid gland has to be able to make more. And if your thyroid gland is kind of like already at the max and it's already pumping out as much as it can, then it's not going to be able to keep up in pregnancy. And that's where we get concerned. So we have to pick a level. Honestly, pick a level. We've the Endocrine Society drew a line in the sand and said it was 2.5. So that is often the value that people use, but it is really just get it close to 2.5, honestly, versus someone it's like 2.6. The other thing about TSH levels, if you guys have had them drawn, you could go in and have your blood drawn 5 days in a row. One day it'll be 2.6, another day it'll be 2.8. It's not always the same. It's not that precise. So as long as you can kind of get it down to 2.5, what it does is it just makes us feel pretty good that you're going to be able to kind of keep up during the pregnancy itself. When you look at TPO antibodies, so TPO antibodies are antibodies against the thyroid. Those women who have normal TSH levels but have high levels of TPO antibodies are probably more likely to be in that population that maybe can't keep up. So if you're already pushing the TSH to be below 2.5, then the TPO antibodies are really irrelevant. But if you are not treating someone, which I actually also think is okay, there are different standards with different societies. So you just have to kind of choose what you're going to follow. If you are a provider, for example, that doesn't treat for a TSH of 3, then it probably is really worthwhile, or 4, for example, which is still normal, but above that level, very worthwhile to check the TPO antibodies because those patients are more likely not going to be able to keep up. All right. So the one question was, would you recommend metformin in a woman with PCOS and a normal A1C who's had multiple losses? The data with metformin does not show that it decreases miscarriages. And if you have not heard of metformin or taken it before, you may not know, but it can have some pretty gnarly side effects and lots of gastrointestinal issues. I tend to put all of my patients on ovasitol, which is a supplement that works in many of the same ways of metformin to kind of really help someone who has PCOS to process their insulin a little bit more efficiently. And so I don't think it's not wrong. It's absolutely not wrong. I think different providers are going to take different takes on it. I think, again, sometimes there's a difference between someone who has PCOS and has not had multiple losses versus some who have. And so if you have PCOS and you have multiple losses, it's kind of getting on metformin is it's as long as you can tolerate the side effects, it is an easy thing to do. And if that's the little thing that's going to make the difference in that patient, it's well worthwhile. So I always think that that is something to consider. If there are issues of sperm fragmentation that can still result in PGT tested normal embryos. Um, so the thing about sperm DNA fragmentation, I'm going to try to answer this, and if I don't, please, you can type in and tell me if I'm not answering it. But the reason it's a little bit more controversial is we're not sure exactly what we can do to solve for abnormal sperm DNA fragmentation. I mean, getting sperm from the testicle is a proposed solution, and there is data to suggest that that can be the thing that will make the difference. Sperm DNA fragmentation is also something that we check with patients going through IVF who just sometimes have really low blastulation rates. So, you have 10 eggs, and when you fertilize it, eight of them became embryos. And in someone who's young, like 32, only one of them becomes a blastocyst. That's your blastulation rate. And so it should be higher. And so we know that sperm DNA fragmentation is also related to that. So the answer is yes. I think what you're asking is like, if you have abnormal sperm DNA fragmentation, can you still get a PGT tested normal embryo? And the answer is yes. It's just really complicated of like, if you're getting that genetically normal embryo, is it still causing a problem or not? Because it's something that is more kind of in just DNA damage in the sperm, not so much as the chromosome. Remember, an embryo being chromosomally normal by PGTA is more of a egg issue than a sperm issue, because the sperm kind of always contribute one copy of 1 through 23. What do I think of the newer testing for the uterine microbiome? Yes, that's the MN, the ALICE test through iGenomics. That usually, oftentimes, if I'm going to do, like, I tend to like to talk about all of these things with my patients. And if you're going to do a biopsy because you're going to look for chronic endometritis, that's looking for inflammation inside the uterus, and you're going to treat with antibiotics. Do one biopsy, you're already there. You could send it for the microbiome as well. So it's something that it's really easy just to kind of add on. So it's something that I will oftentimes consider for my patients. This patient, I had a failed frozen transfer in December with an embryo that it sounds like past PGTA testing, so probably was genetic. We think, and remember, this is the thing about PGTA testing. We think that that embryo is normal, right? So when an embryo tests normal with PGTA, it just means to the extent that the test saw the sections of the DNA that we tested were normal. That does not mean that there are not deletions and duplications in the big chunks of DNA that we're not testing. And so you can still miscarry after having a PGTA embryo. So this patient did a natural cycle transfer. Are those less effective? No. So whether you do a natural cycle or program transfer, those are equally efficacious. The only differences are really, there is maybe some data to suggest that actually those natural, using your own natural hormones, which means that you're ovulating on your own and you're making estrogen and progesterone, and maybe we're supplementing a little bit of progesterone versus just controlling everything by giving you an estrogen and progesterone for a transfer. With the natural cycles, that there might be actually some less pregnancy complications like high blood pressure, preterm delivery. So it's more of like pregnancy complications where there's potentially a benefit for that. I will tell you, with I think a lot of providers, if you've had patients that have had failed implantation, not necessarily miscarriage, but failed implantation, if you've tried one way, either with a natural, you might try a programmed with another just to try to do something different. And that could be kind of the thing that's going to make the difference for that patient. I do not do any other clotting disorders besides just the antiphospholipid antibody syndrome. When I was way back in like residency, we're talking kind of 20 years ago, there was a whole host of things that we would look at, like factor V Leiden and protein C and protein S, and these were all kind of clotting. They're all related to clotting disorders, so they all can increase clots for a patient. And we did that for everybody, and that was like a routine. Like you looked at American Society for Reproductive Medicine, and it said do all of these things. I remember taking my boards and I had to say, like, I did factor V Leiden, I did this. And now there's more data to suggest that those correlations are really not strong at all. And so the recommendations are not to do any of those tests, and there's not any data to support their use. Someone wanted to ask about progesterone levels and early pregnancy loss. There probably is a potential issue with progesterone. Oftentimes we think that that's maybe the mechanism of action of like why thyroid and prolactin can be related to pregnancy losses. They're interfering with progesterone secretion. Adding progesterone and baby aspirin have been like the two kind of easy things that I think most doctors for a very long time just kind of will add for a patient that has had multiple losses. If they decide that maybe they don't want to do IVF, there isn't anything that we can treat and they want to continue to try on their own. It just makes everybody feel different and not feel better, excuse me. They like to do something. And so to make sure that there is that progesterone support, if there happens to be a progesterone issue, and baby aspirin to kind of increase blood flow to the uterus. But I will tell you, there's multiple data to show that it's not helpful. But I will tell you, I often still do it. I don't care that it's not useful, like in like a big population study, because I have the patient in front of me and it might make the difference for them. And I don't know if that is potentially an issue with the progesterone. So it is a very easy thing to do that could potentially have ramifications. Have I seen a relationship between COVID and a miscarriage and then a failed transfer? No, I have not. Not between a miscarriage and then a failed transfer. Nothing that I know about with COVID would, anytime if you were like really sick or something was going on at the time that you were having a transfer, could that affect your immune system? And by affecting your overall immune system, affect something in the uterus? The answer is maybe. And that's why oftentimes if I've had patients that have called me right before a transfer and they're like, I've got a 102 fever, or we'll call off the transfer. Why risk it? These embryos are so precious. Let's just make sure that everything is perfect in that environment so that we're never second guessing what we're doing. If you have miscarriages if two different miscarriages by two different people, would that count as two consecutive? The answer is yes, absolutely, because your body is the same. And a lot of things that we're looking at are more related to the female. The one that is not the male is that chromosome rearrangement. We actually look at the genetics of both the biologic parents. So, I would for sure get that karyotype on you, whether you may say, well, I don't want to get it on my partner. I'd say, okay, but at least let's get it for you. That's probably the most important because you are kind of the common denominator with both of those miscarriages. So someone wanted to talk about ectopic pregnancies. I've had 3 in a row and your fallopian tubes were tested and there's no obstructions. Okay, so the fallopian tubes, what you have to know is that just because your tubes are open does not mean they're normal. If you've had an ectopic inside your tube, I can guarantee you that that tissue inside the fallopian tube is not completely normal. It probably wasn't normal to begin with, which is why you had the ectopic, and certainly the ectopic could increase that, any kind of inflammation. So just because you can get dye to pass through a tube does not mean that tube is normal. And so that is why when you have ectopics, you are just much more likely to have another one in the future. What are the chances of finding reasons for losses when genetic testing was done during the pregnancy and after the losses and no result for the losses were found? I think the answer is that. The question is it still 50% if you've actually done the genetic testing and the genetic testing was normal? I would say it's going to be somewhat similar because a lot of the tests that we're doing, with the exception of the karyotype, most of the tests that we're doing are actually not related to genetics. So it almost would be more likely, if anything, that we would find something. Um, can I share the name of this supplement? Was that the Avasitol supplement for PCOS? I think that was the only one. Would I recommend going to IVF with PGT testing for 3 losses and an FSH of 11? I always think that you should consider IVF if you've had 3 losses. Not saying that you should do it, but you should consider it. And how old you are, how young you are, you may take that into account, because if you are older, you're going to be more likely to have another miscarriage. But if you're younger and you've had 3 losses and you really just want to minimize the chance that you're going to have a loss again, then IVF is your best solution. There's good data to suggest that in young women that have had 3 losses in a row, they can do IVF with PGT or not. Their chance of having a baby at the very end of that journey is probably the same for them. This is for very young women. But if you do IVF, you are going to get to that baby faster and you will have less miscarriages along the way. And so for many people, that is kind of very compelling. Zymot. So Zymot is a microfluidic chip. Can that help with DNA fragmentation? Yes. I routinely use the microfluidic chips or I recommend it for all of my patients going through IVF, because I think everyone could benefit by having less kind of DNA damage to the sperm. It's how you prep the sperm. So if you prep the sperm for IVF, they usually like put it in a tube and then you centrifuge it. And so all the sperm gets down to the bottom. But like, think about it. Think about a roller coaster. It's like Incredicoaster, like Disneyland. It's like shaking you all around. And that's like what we're doing to the sperm. A microfluidic chip is where you just put the sperm and they literally just, the best ones make through a maze. So it's like, think of it as like they're going through one of those box hedge, mazes. They're just kind of moseying along, and the best ones are going to get to the front, and those are the ones we're going to use. And those are the ones that, and you're not doing it without like rattling them. Someone asked, what do you recommend for endometritis? So yes, if there's any sign of inflammation, that would be antibiotics to treat that. I had a miscarriage after 6 weeks and it was a chromosomal deletion. I'm worried about my other frozen embryos. So it depends on that's really hard for me to answer, because it depends on what the deletion and duplication is. And so that's where we always will lean in on our genetic counselors and have them talk to us and then figure out, is this something that is heritable? And so then therefore you need to have your DNA checked and see if it's something that is getting passed down, that you actually need to do a different type of testing in the embryo to test for that deletion, or did they think that it's one of those spontaneous mutations? So I think you would need to talk to your provider and talk to a genetic counselor and kind of work through that. Because yes, I have had patients that have had deletions, and we have done IVF specifically for heritable deletions. Is it common to be ill after? I mean, it can take a while for your body to recover after having a miscarriage, because one, your hormones don't go down all the way right away. And then even when they do, it still takes about a while for your body to adjust. I always say the same thing about like doing an egg retrieval with IVF. Like, yeah, your hormones are totally back to normal when you get your period a week and a half later, but that doesn't mean that you automatically feel better at that week and a half. Like your body might need another couple of weeks to recoup and recover, because those hormonal shifts change things in your body, and then it just needs to readjust and get back to normal before you feel normal. Uh, Someone was asking about the very young patients. Oh, with success using under 35. So patients under 35, that was what the data was. The research studies were looking at in terms of doing IVF or trying on their own, and success rates being the same. And then someone asked about acupuncture and embryo implantation. Yeah, I think acupuncture can be a wonderful addition to any IVF treatment. And so I have lots of patients that will do it as part of like right before a frozen embryo transfer, or sometimes if they're taking time off in between IVF cycles, they'll add that in to their armamentarium. And so I think it's always something that is just worthwhile considering. And I think this might be the last one. If you're 44, do you need to go directly to donor egg? You don't have to do anything. What you need is you need to talk to a provider. You need someone who's going to understand and go through your clinical history, understand where your body is at now at 44, how many eggs are you making? So, for example, if you're going to do IVF, how many eggs might you get at 44? And then have someone walk you through, okay, here are the realistic numbers going through IVF at 44 with your own eggs, testing the embryos and putting them back. You are going to be the person that should be deciding when you're ready to go to donor egg. I truly believe, I know this is not how all other doctors act, but I truly believe like my job is to give you information to help you make the best decision for you. I have patients that are 49 that are going through IVF, right? As long as I feel like I have communicated very clearly, transparently, and honestly what the chances of success are, then I think it's up to that patient to decide what they want to do. And if they would like to do some rounds of IVF before they move on to donor egg, and they want to do those rounds of IVF, even knowing that the chance that it's going to work is less than 1%, and they understand all the risks and complications that could happen with an IVF cycle, which is really low, then we're going to go for it, right? So I think it's just important to have those very honest and sometimes can feel brutal conversations in the beginning. And kind of once you've done that and you've decided you want to do a cycle, like I always say, like I put my different hat on, I put my cheerleader hat on during the cycle, because then we're just going to be positive and just hope for the best, but kind of at the same time always be realistic. So I think yes, like when do you have to go to donor egg? I mean, when you're not making any eggs anymore, right? And we can't get anything to stimulate, that is a time where I literally will be like, I can't do anything, like I can't get an egg to grow. Is there a good definitive testing for birth control induced PCOS? I don't know what birth control induced PCOS is. I have not heard of that. Or PCOS without insulin resistant or elevated testosterone levels. So PCOS is a whole other topic, and it's really complex. And so the definition of PCOS doesn't mean that you have to have elevated testosterone levels. In fact, you may have very normal testosterone levels and still have PCOS. And there are different definitions of PCOS that people use. So it gets complex. So I think you just kind of, at the end of the day, understanding kind of what the issues are for that patient in the moment, in terms of one, what the issues are in their body, and two, also how they're manifesting as clinical symptoms, and then also potentially affecting outcomes. And then just figuring out, okay, what are things that we need to treat and address, and what are things that we don't need to treat and address. Those are really the most important. And I think that was it in terms of questions. I hope this was helpful and useful. If anyone has any other questions, you can always find me on Instagram. I think I always have to just look at like what my Dr. Kristen Bendikson, I know I've changed it. So Dr. Kristen Bendikson, you can find me on social. I also have a website, which is Dr. Kristen Bendikson, but you can find me in any of these ways. Always available to answer questions. It's so important to just have different people's perspectives and hear from different people. People explain things in different ways, and that's how we learn. And if anyone is in Los Angeles and wants to come in, then feel free to reach out, and I'm available. So thank you so much, everybody. I really appreciate you being here today.
Thank you, everyone. If you missed any part of the presentation today, we will be sending a link to the full recording directly to your email, and we'll also have it posted on YouTube. So if you don't find it in your email for some reason, you can find it there. But thank you so much for joining, and happy National Infertility Awareness Week.
Yes, thank you. Thank you so much. Bye, everyone.